proposal's really coming from. So.
This is depression and hopelessness. Mental health and stigma are isolating, and asking for help can be difficult. Calling 911 or going to the emergency room is often the last resort. People are not getting the help they need before it becomes a crisis. People are being held in the emergency room with their dignity and rights being removed, further impacting stigma and the fear of seeking help. But there is hope. Intervention is available. A hope to integrate mental health care, offering nursing, therapy, medication, to help de-escalate the crisis. Reconnecting with others for support. Having access to a psychiatrist 24 hours a day. Bringing balance and equity in mental health treatment. Allowing you to live the life you imagine. Together, a hope-inspired, the mobile psychiatric treatment team. If you want to know more about how you can help, text Hope Inspired to 619-997-1270. There is hope.
And so I've been working on this proposal for the last 2 years. I've worked in inpatient psychiatric hospitals, I've worked in emergency rooms, and I've worked in outpatient psychiatric settings. With all of these opportunities to see at every level of care, there's so many gaps in services. So today I'm going to talk a little bit about the alternative to emergency room boarding. And so just for those of you in the audience who aren't familiar what that is, emergency room boarding is patients going into an emergency room for mental health crisis or medication, or just because they have no place else to go. They end up in the emergency room. Emergency room physicians and emergency room nurses and staff there don't know how to treat patients with mental health issues. And so they're boarded because there's no place to send them. They might be too acute to go to an outpatient setting, and there's no inpatient psychiatric beds. So the problem is, people are seeking emergency room treatment as a last resort. In San Diego County, it's really become the only resort. Outpatient psychiatrists, sometimes there's a 3-month wait list. To get in to see your therapist, it could be sometimes even longer than that. So emergency rooms are the quick place to go. Patients are being evaluated, and then they're sitting in the emergency room for hours, sometimes days. There's no treatment that they're receiving while they're there. Working with patients in the emergency room, their families, patients would walk in, and there was the hope that there was going to be a bed. They're going to go to an inpatient psychiatric facility. There's not enough beds to go to, so they sit and they wait. As an evaluator, all I did was evaluate. I evaluated and determined where there was going to be a bed every single shift. That's what we would do. And there were often no beds for days. So they wouldn't receive any treatment. 2, 3, 4, 5 days later, sometimes they're still sitting in the emergency room waiting. No treatment, no psychiatrist, no meds, just waiting. So why is this happening? Lack of outpatient mental health resources, lack of inpatient psychiatric beds, funding continually being decreased across the, and this is across the US. And then the federal and state laws are not keeping up with the times to prevent emergency. So my initial problem statement, and this is the one that I started 2 years ago, is how might we help people who are suicidal, being held in the emergency room untreated for more than 24 hours while awaiting treatment to transfer to an inpatient psychiatric bed. So while going through this proposal, this project, this was the short term. the 2-year plan that I've worked on is much greater than this, but so I was able to develop this for this setting. So the research shows that lack of outpatient mental health options, decreased number of inpatient beds, these are all very highly publicized. It's in the news. We hear these things, people sitting and waiting. Washington State, they had patients waiting for up to 100 days because they had no alternatives. They finally got funding for Washington State to increase the beds. But the issue is beds the answer? This is a problem across the US. So what did I learn? I learned that even though these stays are occurring for hours and days, this is costly to hospitals, costly to insurance companies, costly emotionally, financially to patients and their families. And then they're still not receiving any treatment. So this problem has been existing for many years. So, like the video showed, they're being held in hallway beds. They're being placed in gowns. They're being monitored by security guards. Their dignity, their respect, it's gone. So the nurses, they don't know how to treat patients with mental health issues. Physicians, they want to defer to inpatient. And so one of the biggest things is, where are they getting the help? We can evaluate them, and that's what most emergency rooms have, is the evaluators. But we're not giving them any treatment. So we're only impacting the crisis. They come in for a crisis, they sit and they wait, they're stigmatized, they're impacted because they're not getting any opportunities for treatment. Sometimes the physicians and the emergency room nurses, their inadequate level of training for their behavioral health treatment or for their behavioral health needs only impact the crisis overall. So from a patient's perspective, working on the inpatient side, I heard it from patients and their families. They did nothing for them in the ER. They sat there for 3 days, and now they're coming here and they're getting discharged from the inpatient setting. Because typically it's only up to 72 hours, right? So, and that's on an involuntary basis. There has to be criteria, and a lot of times the criteria resolves often without, just with time. Unfortunately, without that treatment, they're just languishing. So the ER is exacerbating the problems. The ER has been the main point of entry for psychiatric emergencies, and inpatient psychiatric beds, we've done this. There's a marked disparity between the medical and the mental health treatment that's in the emergency room, and this is one of the biggest things that was devastating as an evaluator, is to try and train the physicians and the nurses in the emergency room about their needs. And it was just a never-ending process. So patients, so now reframing. So my updated problem statement is that patients in psychiatric crisis need to have access to specialized treatment by providers who are trained to treat the presenting problem. By bringing a mobile team of behavioral health providers to the patient, we can challenge the norms that patients can only be treated on an inpatient psychiatric setting. So the mobile psychiatric treatment team is the program that I'm proposing today. It consists of a behavioral health provider. So we're basically going to be taking the inpatient psychiatric treatment team to the emergency room. So this is the redefinition. How might we help people in a behavioral health crisis in the ER obtain mental health care while stabilizing and discharging to appropriate levels of care within 24 hours? So by bringing this level of this team to the emergency room, by offering a behavioral health 24-hour behavioral health team 24 hours a day, providing thorough crisis evaluation, developing safety coping plans, individual group therapy, medication management by a psychiatrist virtually, and follow-up and navigational support for up to 30 days after they discharge, because again, we want to address the patients that are coming back into the hospital, readmitting within 30 days, which is very high for psychiatric patients. So my first prototype, probably about a year ago, was a workflow of what it would look like for patients to who come into the emergency room, they're seen by the emergency room physician, and how the team would actually work with the patients. And I know it's hard to see, but this one we're not working with right now. So the feedback, what I learned was we need to have a room or a space to be able to provide this type of treatment to patients in the hospital. So we need to develop this unit. So drawing this unit, what I envisioned was this living room type setting where patients can walk around in the milieu, that they're able to wear their own clothes, and they're being monitored by the staff, the behavioral health providers that they're working with. We have 23 hours and 59 minutes to be able to treat and refer for where they need to go. So my new convergence sketch was really the workflow. So patients are coming into the emergency room. They're being evaluated, triaged by the nurse. They're being seen by the emergency room physician. They're being medically stabilized. Once they're medically stabilized, the emergency room physician would then make a referral to our team. Our team, being mobile, would come to the hospital. We would then be in our unit, transfer the patient from the emergency room. Our team would begin being evaluated virtually by the psychiatrist, having the psychiatric nurse monitor and oversee the treatment and care, licensed clinical social worker providing that individual therapy, providing that care, engaging their families and friends to really incorporate that social support in the community. And within that 23 hours and 59 minutes, being able to address, are we going to be able to transfer this patient to a lower level of care, or do we need to transfer to an inpatient psychiatric hospital? Or other opportunities out in the community. So one of the things, and this kind of did this exam to our unit, and then they'll be dispositioned within 24 hours. And so that would fall under a billing code. So again, that would be a cost savings, not only to the hospitals because they're decreasing, they're not having people languish in their beds, in the emergency room beds, preventing other people from coming in. So that's really improving the emergency room flow, but it's also, it's a billable service. So working with the hospitals and the insurance companies, both Medi-Cal, Medicare, and so improving the disparity. So we're decreasing that disparity by providing that treatment. Mental health is the only treatment that is referred out from the emergency room. Everything else, they have on-call services, they have consults for all the other medical. Mental health and substance abuse are the only ones that we have to refer off-site to another facility or to another entity to specialties. So in this pilot, we'd be treating about 5 patients a day, or the goal is 1,825 people in the first year in one hospital setting. And so the cost savings, I did some of the research, and looking at the research, no numbers, because it's hard to figure out how much is this one patient costing an emergency room. Because if a patient's sitting there for 3 days, how many other patients could have been in and out of that bed? How is that? So the cost is difficult to determine. So that was one of the difficulties I had in some of the research. But typically, on average, there's 5 patients in several hospitals. I did some of the research as far as there's about 5 patients at a minimum per day in one emergency room. So what are the outcomes? So we want to treat mental health and substance abuse immediately in the emergency room, providing 24-hour crisis intervention, linking patients to the community services that are available, crisis houses, other programs that are out there. Having access to a navigational support person after an intervention like this is going to help decrease that recidivism back into the emergency room. And it's also going to decrease the reliance on inpatient psychiatric hospitals. So hopefully, with a decrease in 5 people waiting for an inpatient bed, we'll be able to treat them. And if we have to transfer 1, there's more space. We might see the offset in the inpatient setting. So ultimately, it's decreasing emergency room boarding, decreasing that 30-day readmission rate, increased equity in mental health treatment, as well as decreasing stigma, and the ultimate one is the cost savings to the community, the consumers, their families, hospitals, and everybody involved. So how do we need to move this forward? We need to move this forward by developing partnerships, money, finding a hospital to be able to implement this program as a pilot, as well as developing policies, procedures, and implementation and testing. It's time we change the trajectory of care. We've had inpatient and outpatient treatment settings for mental health. We've had no other alternative levels of treatment and care. This is where we need to start changing this, the plan for mental health in the mental health system. So the mission and the vision of the mobile psychiatric treatment team is to bring mental health treatment directly to the patient where the patient is in the emergency room, ensuring dignity and respect in a non-stigmatizing setting at the least restrictive level of care. And the vision is to promote mental wellness and to build connections, ensuring a healthier generation.